My name's Monique Gaudino, and I am the office manager at the Stram Center for Integrative Medicine. And just a couple quick technicalities in case you guys didn't know. There are some lime green index cards on all the tables to your left-hand side and also in the back of the room. If you want to take one and a pencil during the lecture that Dr. Stram will give, you can go ahead and write your questions down, and then we'll have somebody collect them after the lecture. You guys will pass them over to your left. So just some quick technicalities. But welcome again. It's so nice to see everyone, some familiar faces, some new faces. We're very happy to do this tonight to spread awareness for Lyme disease and also to educate the community about Lyme disease as well. I have a couple thank yous to begin the night. I'd like to thank Chris Fisk of the Lyme Action Network and Holly Ahern. They're over here on the side on the middle table. Thank you guys for coming. You'll be hearing from Chris Fisk a little bit later too. I'd also like to thank Barbara and Linda Decker of the Empire Lyme Association. They're the table on the end over there, and they'll be here after the lecture as well. And then I'd also like to thank Heidi Buono for spreading awareness about this lecture too. So thank you guys very much. And we have a pretty full, yes. We have a pretty full evening tonight. First, Dr. Stram will talk with his lecture about Lyme disease, about the symptoms, the treatments, the misconceptions all surrounding Lyme. Next, Chris Fisk will speak briefly about the policies and legislation surrounding Lyme disease. And finally, we'll have a question and answer session. We'll try and answer as many of those questions from the index cards as possible as we can. So let's get started. First, I'll begin by introducing Dr. Ronald Stram. Dr. Stram is the founder and the medical director of the Stram Center for Integrative Medicine. He opened the doors to the Stram Center to the Delmar community and beyond over 10 years ago. He is fellowship trained by world-renowned Dr. Andrew Weil. He's trained in and practices emergency medicine, and he's been practicing medicine for over 25 years now. He is a true pioneer, and he is a true inspiration to all of us who work alongside him. So without further ado, it is my pleasure and my privilege to welcome Dr. Ronald Stram. Thank
you. Thank you, everyone. Thanks for coming. Thank you, Monique, for doing this. I thought I would try to trip up the stairs just to kind of add some lightness, because I know this is somewhat of a heavy subject. You know, I think what we would like to do and what we're doing here today is really to present two sides of the story. And that's really what I hope that I will do, and give you the evidence to support maybe this side of the story. But there are two camps. The first camp says that Lyme is a simple disease, it's a rare illness, it's easy to avoid, it's simple to diagnose, it's easily treated, and it can be cured within 30 days or less with the use of antibiotics. What we have seen and what we have seen in our practice is that this is probably very far from what is reality, at least with many patients. What is also important for us to all know is that scientific knowledge is a continuously evolving process, and recognizing how today's paradigms have been arrived at is a critical way of understanding how the future and how advances and continual understanding of the intake of information can change treatments. What do we do at the Stram Center? So what we believe is that the only way to truly care for people is through a whole system approach. The biography, what is your story? We believe that lifestyle and nutrition are paramount. And in fact, this is not new. Tuberculosis, which had no real curative treatment 60, 70 years ago, what did they do? The best treatment was putting people in sanatoriums. Sanatoriums where good food, clean air, and lifestyle improve people's outcomes. This is still the same whether this is an infectious disease like Lyme or high blood pressure or cancer. That the biology of you as the individual is also very significant. Why is it that some people that get a tick bite and get Lyme disease, maybe treated, not treated, 3 months later they have a test, they get tested, they become positive, they're treated for 3 weeks, and they're better? Why is it that some people that get treated take months or years to get better? What we found is that there are certain inherent issues with people's biography, with their own biochemical terrain, which can make them more susceptible to having a more challenging course of their disease. And then understanding the biology of Lyme disease in itself is to know that the bacteria is a very complicated and challenging bacteria, one of the more complex bacteria that I myself have come across. So the first question is, what happens if by some chance I notice that I have a tick bite? And just to give you some statistical data, in Dutchess County, those people that have known Lyme disease, they've been diagnosed by having a erythema migrans or a bullseye rash. They have a CDC positive Lyme test, and they have symptoms suggestive of Lyme disease. Maybe it's joint pain or numbness in their face, weakness in their muscles like Bell's palsy. Those people, known definitive diagnosis, only less than 20% of them recall ever being bit by a tick. So that's only 1 out of 5, right, or even less. But if you do know that you got bit by a tick, and that's often not easy because the nymphs of ticks are very, very small, maybe the size of poppy seeds. And they're tricky buggers too, because what they do is they inject an anesthetic while they attach to you. So typically most people don't feel them unless you're sort of washing yourself or you're looking over and all of a sudden you see that thing that looks like a little scab and then you try to pick at it and you see it moves, you go, but that's kind of this little guy. So what I believe is guidelines are guidelines, and that's often what guidelines are to be. They're not mandated prescriptions. And guidelines should be based on evidence to support how they benefit people. What we have to look at is, so what's the evidence to support treatment versus no treatment? What's the risk-benefit ratio? Do we allow clinicians and patients to form their own clinical judgment and come together as a partnership so that we can come up with some plan of action, some plan of treatment? Do we recognize that every one of us has our own values, our own preferences? And then, by not treating, are we being morally, ethically responsible? And are we delivering what we all want is compassionate care? So according to the IDSA website of 2012, for a tick to infect a host, it typically must be attached to the skin for at least 36 hours. For prevention of Lyme disease after a recognized tick bite, routine use of antimicrobial prophylaxis is not recommended. A single dose of doxycycline may be offered to adult patients and to children greater than 8 years old, and only when all the following circumstances exist. The attached tick can be reliably identified as an adult or a nymph, that it is estimated to be on the skin for greater than 36 hours on the basis of the degree of engorgement and with certainty that blood or blood products have been exposed. Now, let me ask you, has anyone really known that they've had a tick bite for 36 hours?
Oh, no, I had it for much less.
Okay, well, let's keep going. So the IDSA, again, this is according to what is believed as evidence-based medicine, and these were the conclusions that were drawn in 2006. And typically, guidelines change every 5 to 6 years, just because, as we just spoke about, the evolution of care typically changes. If we go with tuberculosis, in 1944, there was only one drug for treatment. What was quickly found is that, yes, it did help, but after about a month of treatment, patients developed resistance. What was noticed is that 2 medications given simultaneously reduced the resistance from the bacteria. Initial treatment was offered for a month, shown ineffective. Then it was offered for 3 months. It was continued to show ineffective because resistance developed. It was then understood that 2 drugs were not effective enough, and 3 drugs became the norm. But that was in the 70s. Then in the 80s, 4 drugs were used. Initially, the 3 drugs were used, but for 2 years. And then 4 drugs were used for 6 months. This is based on the evolution of scientific data and adhering to what we learn as physicians and as practitioners that listen to your patients and let them guide you in your treatment. The vast majority of Lyme meets the CDC surveillance criteria. You get an EM rash. And how often is an EM rash? How often is an erythema migrans rash or a bullseye rash? What's stated is that it's about 30%. What's true is there is a rash about 30% of the time, and there's an erythema migrans rash about 1/3 of that. So in actuality, most people only get an EM rash about 10% of the time. Bell's palsy, yes, common, but I will tell you that I have seen very little of it except in the emergency room setting, and then one doesn't really know if that's Lyme disease. Heart block is relatively rare, and meningitis is also relatively rare, although signs of neurological dysfunction are relatively common. And arthritis is, if not almost universal. Laboratory testing using ELISA as a screen, which is typically the first test you get, the sensitivity of that test is somewhere between 30 to 35%. So it's difficult to say if that's the first test you get, that will then, if you have that as positive, you go on to the next test, which is a Western blot, which is more sensitive. Why would you use a test that is less sensitive to begin with to go with a next test that is more sensitive? When in the end, the CDC doesn't recognize the ELISA as a true test showing positivity.